Good afternoon, everyone. This is Dr. Pascual, and I'll be lecturing to you on the dark side of stroke, monitoring and anticipating complications. So now, for some learning outcomes after this lecture, you will learn to anticipate and prevent complications of stroke, which may be neurological or non-neurological. In doing so, you will know which signs and symptoms to look out for clinically when your patients so that you can avoid potentially preventable complications. Now here is a sample health management record, also known as the order sheet, showing you the basic orders that we would order for most stroke patients who need critical monitoring. So what could possibly go wrong? This should be our mindset when we are treating our acute stroke patients. So the thing that we don't want to happen the most is death. As you can see here, most of the deaths are neurological in terms of brain herniation, but they can also expire due to pneumonia, cardiac reasons, or pulmonary embolism. So as to the neurological versus non-neurological complications, they are listed here, and we will go through them one by one. Now, when we're talking about brain herniation, just a review, this means the brain herniates from one compartment to another due to a differential in the intracranial pressure. So when you have an elevated intracranial pressure, what moves out first is the venous blood, followed by the cerebrospinal fluid, and ultimately brain tissue when we are too late. So what happens when you have, what could lead to increased intracranial pressure in acute stroke is if you have a large stroke, such as a large infarct, or a large intracerebral hemorrhage, or subarachnoid hemorrhage from ruptured aneurysm. So any of these three will add volume to a very tight compartment, such as the skull. So in terms of cerebral infarction or ischemic strokes, we want to avoid the expansion of the territory at risk. So we want to keep our infarct small. So if we can reverse the occlusion, we do so with thrombolysis. Now, what could go wrong? A cerebral infarction territory can evolve and continue to enlarge if you don't control the blood sugar of the patient. That's why, and we emphasize in different colors sometimes, and we write down in the chart that we want the capillary blood glucose monitored closely in these patients. What else could go wrong? Some of our middle cerebral artery infarctions can swell in what we call the malignant MCA syndrome. So this malignant edema can be very disastrous for our patients. So when do we expect the neurological deterioration in our patients with a large stroke? It usually occurs within the first 48 hours of onset. So this is the reason why we don't want to add any dextrose containing fluids. We want to have isotonic fluid so that we do not add to the cerebral edema. That's the reason for the 0.9 normal saline solution. Now, something that can go wrong when we are doing thrombolysis in our acute stroke patients who come in within the first 3 to 4.5 hours from onset is a symptomatic intracranial hemorrhage. So what could lead to this symptomatic ICH, other than the size of the infarct, could be uncontrolled hyperglycemia. Then this has been noticed not just during our intravenous thrombolysis, but can also be seen after intra-arterial thrombolysis. How about for intracerebral hemorrhages? What could go wrong? We can have an expansion of the hematoma, or it could be still expanding at the time when we receive the patient under our care in the emergency room. So how do you anticipate which patients will have continued hematoma growth? Well, if you get these patients within 6 hours and you do the CT scan, whatever you see on the scan will not be the finalized size of that hemorrhage. So it has been shown that CT scan done 6 hours or less from onset has a tendency to predict that these patients' cerebral hematomas are not yet finalized in size. They are still growing when we receive them. Of course, the use of anticoagulants, so those patients who are over anticoagulated with warfarin will have a high risk of continued hematoma growth because of the abnormal bleeding parameters or clotting factors. The baseline size of a hematoma. So some studies have shown that with larger hematomas from 30 to 60 or more than 60 ml of blood, the highest risk are for those with large intracerebral hemorrhages because the reason is that they're already so big and they're continuing to grow. No tamponade is occurring. For those who have the luxury of performing a CT angiogram at the time of getting the patients at the ER, they may pick up the so-called CT angiogram dot sign or spot sign. Now, here is a closer look. So right there is the CT scan angiogram spot sign, which shows you a actual blood vessel bleeding at the time of the scan, forming this hematoma. What else could go wrong? If they do not expand or they are large in size, the hematomas may have an initial perilesional edema or a delayed perilesional edema. So the edema that forms within the first 24 to 48 hours in intracerebral hemorrhages are attributed to the clot retraction. And so those plasma products or degradation products may form a mass effect around the intracerebral hematoma. This occurs early in the course of our patients with ICH. But a delayed second peak of perihematomal edema can occur from 3 days onwards post-ictus. So something to watch out for, the so-called delayed cerebral edema in patients with intracerebral hemorrhages. So around this intracerebral hemorrhage, you have this swelling around the hemorrhages, causing a very significant midline shift and hydrocephalus over here. You see here the intraventricular extension of that hematoma. Yeah, as mentioned in the previous slide, the leakage of the blood into the ventricles forms another problem for us if that clogs up the ventricular system, leading to an obstructive or non-communicating type of hydrocephalus. Okay, as shown here, you see here the hematoma and some blood here in the lateral ventricle, and mostly the mass effect of the perilesional edema as well adding to the picture, compressing on the third ventricle, and you see here the enlargement of the contralateral lateral ventricle. Worse, what can go wrong is if we don't control the blood pressure in some of our intracerebral hemorrhage patients, another hematoma may form on another site, such as seen here. The initial hematoma in this patient is in the right basal ganglia, and another hematoma over here in the left frontal region at another time. This is a repeat CT scan. I'm just showing you the upper slices of the CT scan, showing you this new hematoma formation over here. What about aneurysmal subarachnoid hemorrhages? You can also have increased ICP in certain situations. And the worst one, and the one we want to prevent by securing that aneurysm early, is the rebleed of that aneurysm. So as you can see here, this was the initial CT scan on the left side of the screen. A subsequent CT scan showing an expansion, meaning a rebleeding from that documented aneurysm. So when will rebleeding occur in your aneurysmal subarachnoid hemorrhages? For one, if you've already documented a sizable intracerebral hematoma, not just subarachnoid hemorrhage around the site of the aneurysm, this is a very bad sign. This means there can be a rebleed if there is already an uncontrolled expansion of hematoma in the parenchyma around that aneurysm. High blood pressure on admission, more than 160 millimeters mercury systolic, is also a bad sign. So you anticipate that these patients are at high risk for rebleeding if you cannot control the systolic blood pressure of these patients with aneurysmal subarachnoid hemorrhage. Now, if you manage to document the aneurysm in an angiogram, like a CT scan angiogram, you might locate the aneurysm might be located in the basilar artery, and these are particularly prone to rebleeding. The size of the aneurysm matters also, so it's been documented that aneurysms more than 9 millimeters in size may rupture. And of course, we always have to anticipate hydrocephalus. So for patients with aneurysmal subarachnoid hemorrhages, sometimes it's the hydrocephalus itself or the intervention that we do for these patients which can cause a re-rupture of the hemorrhages. So naturally, the neurosurgeons will be hesitant to perform a tube extra cranial ventricular drainage. Another cause for increased intracranial pressure when aneurysms rupture, the complication of vasospasm. If left unmanaged, it can lead to ischemia and an infarction, as we can see here on this picture. So this is a left ACA, anterior communicating artery aneurysm, and this is a vasospasm in the left ACA territory. Since it's a large territory of this particular ACA, it can also lead to cerebral edema. Okay, so edema can occur whether globally, diffuse cerebral edema if the blood products are all over the place in the subarachnoid space, or due to a infarct, a large territorial infarct that swells days after the insult. In any case that blood leaks into the intraventricular space, it can lead to clogging up of the cisterns or from the ventricles themselves, leading to hydrocephalus. Now, what are you watching out for? What do you write down in the chart? What do you look for when you're at the bedside in these patients? The thing you don't want to see is anisocoria. Okay, anisocoria is shown in this example where there's a marked difference in the size of the pupils. It's blown here on the left, smaller on the right. If you caught this patient earlier, you can actually catch them with equal sized pupils, but one pupil is already sluggish compared to the other pupil. Okay, what we don't want to happen is for supratentorial structures to herniate into the posterior fossa. You can expect damage to the structures here in the diencephalon and in the mesencephalon over here, the midbrain. So, with the distortion of the cerebral tissue, clinically, your patient will manifest with decreased sensorium if they did not already present before the anisocoria. So, in this situation, we see here from a normal intracranial pressure at this point of no return. So, a diffuse increase in the ICP over here. So, that's the increasing ICP. It leads to a decrease in the measurement of the cerebral perfusion. So cerebral perfusion pressure, how much blood enters the brain. So you see here a inverse relationship with increasing ICP. Expect less blood flow to the brain until it becomes an irreversible state. So the cerebral circulatory arrest or brain death ensues over here. At the point of no return, if for any reason the arterial blood pressure drops, that's when the perfusion suffers. So as you can see here, in states of increased ICP, the perfusion pressure now depends on how high the blood pressure is for that patient. Okay, so the point of no return. Has a very poor prognosis.
Nothing can stop that now.
But it doesn't stop there. Yes, it has already been documented. If you can quickly reverse that herniation, patients will survive. No, as long as you can manage it by recognizing the situation a lot earlier. Okay, so what do you watch out for? That's why we write it in the chart. If you need to highlight with a different color, please do. So if your patient was alert or drowsy at the beginning and now they're no longer arousable to pain, so this is what we're watching out for: decreasing sensorium. And of course, the unequal size and reactivity of the pupils. Okay, just derive this from the UCSD so-called brain code. The emphasis here is right here on the left side of the screen. This is how much time you have to act once the brain code has been called. So if the patient is not yet intubated, you intubate the patient now, and then you hyperventilate with that ambu bag at 30 to 40 breaths per minute, bearing in mind that you want to induce the hypocapnia by lowering the CO2 quickly to 25 to 30 millimeters mercury. Also, within that first 5 minutes, you already mandated to manage the ABCs of that patient, and you want to quickly manage the herniation. So you want to give osmotherapy. So here, if the patient came in, we estimated her to have 60 kilogram body weight. We know that mannitol is 20% solution. So at 0.5 grams per kilogram, this is the recommended dose because we don't want to cause other problems like acute kidney injury. So 0.5 grams per kilogram would give you 150 cc's or ml of mannitol, which is given as a bolus over 20 minutes. And then you maintain that for every 4 to 6 hours. Okay. At the same time, this brain code advises giving hypertonic saline. So we should give this ideally in a central line, but you may use a peripheral line if it's good and it's a large bore catheter. So you give a bolus, 250 cc IV bolus over 15 minutes, and you want to repeat that serum sodium every 6 hours to target a 150 to 155 millimoles per liter serum sodium concentration. Other measures you can do is to elevate the head of the bed to 30 degrees to maintain the drainage of blood from the brain without compromising perfusion. To not compromise your venous drainage, you want to keep the neck straight and the head at the midline. Of course, you want to refer to our friends in neurosurgery. So here is a graph of all the possible complications in our stroke patients. So this was a study done in 1984. The complications that may occur within the first week in the stroke patients are usually the transtentorial herniations. Here we see the actual time course, the waves of our anticipated complications. The first wave, as you can see here, for intracerebral hemorrhages is within the first week. Then you have the two peaks. The first peak of that wave is over here initially, but we do not become complacent because there is a second wave that may occur after 3 days onwards, 72 hours onwards. This is the delayed cerebral edema. Now contrast this with the cerebral infarctions, which will occur days later. We typically tell our patients that the point of maximal cerebral edema will be in the next 2 to 3 days before it subsides. So this is the critical period in our ischemic strokes. They will not herniate at the onset. Okay, so this is for ischemic strokes. Then of course the third peak will be those from infections, which is the next topic. A large stroke trial, the ANOS trial, they documented the majority of infections were due to pneumonia, so 66%, followed by UTIs. here at almost 20%. So this is a study done by our current stroke fellow, Dr. De Castillo. This looked at the predictors for pneumonia in acute stroke patients. And just to highlight the main reason or the main factor leading to pneumonias is the presence of dysphagia. So very significant. Okay, that's why we do not feed our patients until we are sure about their swallowing status. Talking about aspiration pneumonia, the typical cultured organisms from aspiration pneumonia are expectedly the oral flora. So how can we avoid aspiration pneumonia? One step would be oral hygiene. That means cleaning the tongue and the palate of our stroke patients as a basic standard of care. If they're awake enough or cooperative enough and we know that their swallowing status, they are slightly dysphagic, then measures that you can do to avoid aspiration would be the so-called chin tuck and the chin down maneuvers to help push the food into the esophagus. We need to assess the swallowing status with the dysphagia screen. Just a reminder that we insert the tubes not to prevent aspiration pneumonia, but to prevent the aspiration of the feeding. Most of the stroke patients will have those micro aspirations, even if they are intubated, even if they have NGTs, if they have PEGs. We are just instituting this measure, inserting an NGT to prevent the macro type of aspiration, which is why if they are able to swallow, it's best that they do it naturally, but they institute strict aspiration precautions and they do the chin tuck maneuver. Other things we can do, since not too many RCTs have been done to see what measures can prevent aspiration pneumonias. Positioning is a factor. This is based on physiology, so you do not want the contents of the stomach to backflow. That's why we do high back rest till 2 hours after feeding. Okay, let's talk about UTI in stroke, how to avoid these. First step is, does your patient really need to have a Foley catheter? Okay, so experts from the CDC would recommend that you do not insert a Foley catheter unless the patient has a urinary retention or incontinence to justify inserting that catheter. Another reason, which is compatible with or what we do with our stroke patients, is the need for accurate I&O. So when you ask for a accurate input-output monitoring, you need an accurate urine output monitoring. You also want to anticipate that if you have patients with decupitous ulcers or ulcers in the genital area, a Foley catheter would help to prevent urine spillage on these open wounds. And of course, stroke patients are expectedly going to be immobilized for a long time. So this will justify placing that indwelling catheter. But it was highlighted by the CDC that inserting a catheter is not a substitute for good nursing care in the incontinent patient. It's just a measure to help prevent complications. So solutions for these situations when you need to get a urine sample is to use the so-called condom catheters if your patients are cooperative males who do not have urinary retention or a bladder obstruction from a prostate enlargement. The next complications are the cardiovascular events in stroke patients. So, as you can see in this graph, the final component of this graph of complications in stroke patients is due to cardiac complications. As you can see, it's slight peak during the first week and then it maintains a risk for cardiac complications post-stroke onward, several weeks onwards. Okay, so what are the possible cardiovascular complications? You can have MI, you can have cardiac arrhythmias, pulmonary embolism, and sudden death. The deaths that we are not anticipating, which we should anticipate. Okay, so for MI, our stroke patients have a risk of 2% of getting an MI after the stroke. Most of the time, they are NSTEMIs, so non-ST segment elevation MIs. Now, how do we anticipate this? So the risk factors for sudden death have been shown to be 1, the severity of the stroke, and 2, the presence of a prolonged QT segment on the ECG. So these are significant predictors for cardiac mortality in our stroke patients. So we have to watch this on the cardiac monitors if we catch this on the baseline ECG. Okay, so how to anticipate and prevent sudden death? Is it possible? Okay, so the history of a cardiac disease or the kidney disease and diabetes should alert you of these possible complications. The presence of an insular involvement on the imaging studies. Now let's talk about this. Okay, what is the insula? It's the brain within the brain here in the cerebral cortex, this island of gray tissue hidden underneath the frontal and temporal and parietal cortex. So there has been documented localization of autonomic control in the cerebral cortex. For the right insula, it has been documented that the sympathetic control emanates from here, while the left insula has been documented to have preferential control over the parasympathetic nervous system. Let's say the stroke is on the right middle cerebral artery territory, which will affect the insula on the right side. It has been documented, and we need to watch out for bradycardia or even asystole in these patients with the right insular lesions. In contrast, if it's a left middle cerebral artery infarction, which may damage the left insula, these patients may present with tachycardia or uncontrolled hypertension. So knowing that they have insular involvement, then you have to monitor what's going on. Myocardial injuries can occur with insular lesions or insular damage. While it may be controversial to monitor the troponins, if it's been documented to be elevated and there is no sign of myocardial ischemia, you may consider it to be due to the insular damage. An ECG is routine just to catch if there are arrhythmogenic disorders, whether it's familial or it's an acquired prolonged QT interval. These patients must be put on a cardiac monitor for at least 24 hours after admission. If they are normal, they might need to do Holter monitoring for longer periods to catch these paroxysmal arrhythmias. Of course, we complete the workup. A transesophageal echo is preferred to catch those poorly seen lesions in the atrium, in the atria. Now let's go to the venous thromboembolisms. Some patients are particularly at risk for thromboembolisms. And these are the patients who have severe strokes, who have a decreased sensorium, the comatose patients, those with a history of cancer, or those with a known prothrombotic state. Now the common denominator of the first 3 bullets here is immobility. So these patients are not mobile and are at high risk of developing deep leg vein thrombosis. For patients with risk for VTEs, we may put them on intermittent pneumatic compression devices. The only thing we have to watch out for is the skin. If they are developing skin ulcers, we have to avoid that, or we have to prevent that by frequent rest periods from the devices. If the high risk for VTE offsets the increased risk of bleeding, then we are justified in giving low molecular weight heparinoids. For the hemorrhagic stroke patients, those with ICH and SAH, we can also put them on the IPCs and add elastic stockings if we do not have the IPC devices, or we cannot give the low molecular weight heparinoids. Now going to the possible metabolic derangements in stroke patients. These are the more common metabolic abnormalities in acute stroke patients: the hyperglycemic patients which may not necessarily be diabetic but may be stress hyperglycemia. You can have disorders in sodium levels and occasionally hypokalemia. Okay, those patients with stress hyperglycemia have been documented to have higher mortality compared with those with normal glucose levels. Now, the European Stroke Organization recommends that we control the sugar but not too low. So the recommended targets are between 7.8 to 10 millimoles per liter. And you do not want to induce hypoglycemic episodes which can cause further brain damage. You emphasize to the team that you want the capillary blood glucose to be monitored regularly and referred to you if too low or too high. Lastly, let's talk about falls in stroke patients. Now, this is very avoidable and preventable. Okay, who are the stroke patients at risk for falls? These are the aphasic patients or those patients with impaired spatial orientation. Okay, so when do these falls tend to occur? Now, this is something that the hospital and the nursing staff can help to avoid, knowing that most of the falls tend to occur at night and during the first 5 days of hospitalization. So knowing the deficits of the patient will help prevent this and keeping rails up for these patients at risk for falls. So these are the universal fall precautions for stroke patients. Sturdy handrails, not just for the hospital bed, but in the bathroom, the room, and the hallway. Now, in terms of the hospital bed, if possible, if not an ICU bed, they keep the bed at the lower position with the brakes locked. Okay, so that is my final slide. I hope you learned something from this presentation. And whatever we do what's best for patients. Thank you.
Everything is proceeding as I have foreseen.